Welcome to today's topic on snoring to serious habitual snoring, which is harmless, only a nuisance to the spouse. It's harmless, it doesn't cause any ill effect. That is what we habitual snoring. Going to serious, as it progresses, it can be quite dangerous. Heart attack at night, having a stroke at night, and even death at night. Disclosure, just some relationship with Home to Home, who's a sponsor today. They actually do sleep studies and also sell machines. Overview today, we'll be talking about snoring, sleep disordered breathing. Our emphasis will be on obstructive sleep apnea, where there is actually obstruction in the upper airways. Sleep studies, different levels of sleep studies, treatment options available, and how you can spot OSA from afar. What is snoring? How does snoring come along? It's actually vibration noises during breathing in. It's caused by the floppy part of the upper airways. You have the upper airways, right? But you are not snoring. But for those who snore, why they snore? It is because during sleep, all these muscles go into relaxation and they become floppy, loss of tone, and then they fall back, especially if one lies at the back. So that's why when the air goes through, partially there will be fluttering noises, and that is the snoring. And when there is no noise, because there's no airflow, that is when we call it apnea, when it is more than 10 seconds and beyond. 10 seconds and beyond is the definition for apnea. So when there's no airflow, that's the dangerous part. When it's silent, that is the danger. It can last for 10 seconds. We have even patients having this apnea for 30 seconds, 40 seconds, very long. So in this little graph, you can see snoring is actually a spectrum from no disease, habitual snorers, to obstructive sleep apnea. And you can see also varying degrees from upper airway resistance, just air having some difficulty passing through to narrow airway passages, like in the nose or in the throat, but no apnea. That means there's no stoppage of breathing. So mild, moderate, and severe. Severe are the ones that we should take note. So it's a spectrum moving across. And when one has mild sleep apnea, over time, as one ages, it usually becomes worse. So as we mentioned, it occurs mainly during sleep, especially deep sleep, and even worse during REM sleep, rapid eye movement sleep. That is when all our muscles goes into relaxation and this obstruction will be at the greatest. And when it is at the greatest during REM sleep, some of the spouses will not be able to observe the snoring. You know why? Because the spouse says, the snoring is not that bad. Not that bad. No apnea, no choking. But the person actually has it very badly. They do a sleep study, it's very bad. Why? The question we will be asking ourselves, when does REM sleep occur most often? So REM sleep, the deep part sleep where we dream, actually occurs in the latest half part of the night when we sleep, or the last 1/3. So meaning to say, the spouse will have slept very deeply as well. So will not be able to recognize the deep obstruction there is silent. So if the obstruction it is not so bad, it will be half breathing, that means hypopnea. That means there's still airflow, there's still this noise, but the airflow is partial, less than 50%. Apnea or hypopnea events occur and oxygen desaturation follows. So there's an apnea event, stop breathing, obstructed, air cannot go through, oxygen level will fall. And there is usually a slight delay. As you can see here, no breathing, totally obstructed. Oxygen initially was higher, has come down, and it can drop very significantly. We have patients who drop their oxygen saturation from normal, like 97, 98, at least above 95%. So when it drops, it can drop down to sometimes can be as bad as 60, 70%. And if the spouse is observant, especially if there's repeated apneas, and the apneas are very long, the person is actually quite, if you see properly with some light in the bedroom, actually is blue. The person is actually blue in color. So we be very careful. So oxygen drops usually more than 3 to 4%. And obstructive sleep apnea is quite common. Some studies say that in the general population, men about 34%, women 17%. And it increases with age. And for women, after menopause, it catches up with the men. And of course, obesity. And you can see the obstruction can be in any area, nasopharynx, laryngopharynx, and the oropharynx here. So the sites of airflow obstruction could be many, like in the nasal cavity, deviated nasal septum, and large turbinates, those with nasal allergy, born with a deviated nasal septum. And for children, especially children, adenoids. Children, if they have obstructive sleep apnea, are more amenable to surgery because their airways are small and tiny, because they are small babies, right? Children are small. So when the airways are small at their age, and if the adenoids or tonsils are enlarged, in proportion to us adults, the obstruction would be quite severe. So by having the adenoids removed or the tonsils removed, you find that they can actually get out of this obstruction. Whereas in adults like us, may not be. So we can remove our tonsils, even if large, it may not cure the obstruction or bypass the obstruction. So large tonsils, soft palate, the roof up here, soft palate, and the uvula, Chinese call it the diuzhong. Sometimes it's very long and thick, and then can cause obstruction. The uvula is very long and thick, will be here, coming down. The hypopharynx, large tongue. This is the tongue. If the tongue is very large, then obviously it's going to block at night. And fat deposits around the throat, outside. So when they have a big neck, because of fat, there will be compression. The skin can only stretch up to a point. Otherwise, it will be, the fat will be going inside. To find out exactly where the problem is, sometimes ENT surgeons do the drug-induced sleep endoscopy. They will induce persons with the symptoms of loud snoring and all, give them propofol and then scope and find out where exactly the obstruction is. Then they can perform better surgery. Otherwise, you cut here, cut the wrong place, won't get cure. And the symptoms of OSA, excessive daytime sleepiness. So you can score yourself whether you have excessive daytime sleepiness or not. Loud snoring. Snoring is usually present. Can be very loud. Not so loud, sometimes you see it's thunderous. Even the whole bed will vibrate. It can't be so loud, sometimes it can be quite nuisance to the spouse. Witness apnea. The person snore and then stop breathing. The spouse will look up, how come not breathing at all? And then most of the time the spouse will say, wake up, because you see the person's changed. The spouse will know how the person has changed. When the person starts to breathe again, gasp and choke to open up the airways, because he had to tighten up the muscle so that the airway open up again, you see, because during the obstruction, the muscles are very relaxed. So he has to tighten up the muscles, and then it causes this gasping or choking. This kind of sound, but usually very bad. And of course, because of the obstruction and the fall in oxygen, then you find that the person has to wake up because the body internally detects low oxygen, asks the person to wake up. And if the person wakes up many times, like severe OSA, more than 30 events per hour, sometimes you can have 60, 70 events per hour. So they don't get good deep sleep. The very minute they go to take the obstruct, oxygen drops, detected by the brain, says, wake up, wake up, wake up, wake up many times, 60 times, 50 times per hour. Definitely no good sleep. So you get unrefreshing sleep. And because by nature, if somewhere is blocked, the person will usually open the mouth to breathe. It's only natural, isn't it? If something here, and whenever you block, you open our mouth quickly to try to breathe. That's why you get dry mouth. And sometimes sore throat, especially if the upper airways are very much enlarged because of the floppy, many beating against each other. The floppiness making the sound many times per hour. it gets sore and raw. So you get sore throat. So those are the symptoms of OSA. So this is the Epworth Sleepiness Scale. I won't go through it, you have it. So essentially, to score these A parameters, like sitting and reading, do you doze off? So the question would be, how likely are you going to doze off in these A situations? Would never doze off. Slight chance of dozing off, moderate chance of dozing off, high chance of dozing off. So you score each of the three events, like sitting and reading, watching TV. Like the last example, in a car, stop for a few minutes in the traffic, how are you likely to doze off? If you doze off, that would be bad, very, very severe, because the car all passing by and driving, and then just reverse while waiting for the light to turn green, you already fallen asleep. Oh, that's very dangerous, very, very dangerous. The situation, of course, the earlier situations are actually when it's a more relaxed situation. Interpretation, if it is 11 and above, if you total up your score and it's more than 11 and above, then you have excessive daytime sleepiness. It can be divided into mild, moderate, and severe. That's how you use the score. Symptoms of OSA, because of poor sleep, morning headache, irritable, scold the spouse, depressed, even sometimes sexual dysfunction, erectile dysfunction as well, difficulty concentrating, poor memory, reduced productivity, obviously, and of course, how do they get into motor or work-related accidents? How? But this is a very dangerous one. The car is split into two. So why is it dangerous? Just like you are driving, how much can you push your car in the highway, north-south highway? How much can you push your car? 110, right? Allowed, isn't it? 115, the police will come after you. At 110, it's unlikely that you actually fall asleep, but it is a micro sleep. Because you're driving at such a high speed, micro sleep means few seconds at high speed, you can actually go off course, especially if it's a winding road. A few seconds at high speed can cause an accident. So there are many causes of hypersomnolence, that means excessive daytime sleepiness, like sleep disorders. We are only concentrating on sleep apnea. There's such thing as narcolepsy, idiopathic hypersomnolence, medical conditions like hypothyroidism, depression. This one we have to rule out. This narcolepsy, we have to do full sleep study and also multiple latency tests. And medication, substance abuse, and also sleep deficit deprivation. This is very common. If you don't get enough sleep, obviously the next day you'll be more sleepy. So sleep deficit and deprivation, very important cause of excessive daytime sleepiness. In sleep apnea, the person will be snoring. This one, it may not, because they just don't have enough sleep. So the commonest cause of excessive daytime sleepiness is actually sleep deprivation, depth or deficit. How many hours do you require? I think some are middle-aged, some are more elderly. So minimum 7 hours. You should get 7 hours of sleep, and more if you are younger. Naps are good, but they cannot replace full sleep at night. A good sleep at night is still very essential. Naps cannot. Even if you take naps, and naps shouldn't last more than half an hour, because we don't want the napping to go too deep. You sleep too deeply during the nap, you come out groggy, and you're not going to be very productive in your work. So usually less than half an hour. Sleep cycle, usually there are about 4 to 6 cycles per night, different stages. So when you're awake, then you can go fall asleep, going to stage 1, light sleep, and then finally stage 3, deep sleep, restful sleep, where you get restoration of the body, physically, immunity and all. And you get the REM sleep, where you dream. It's also very important for the memory and everything to be organized, and that occurs during REM sleep. REM sleep, rapid eye movement sleep, is actually the eyes dart. If you look at young children, some of them, when they sleep, their eyes dart. That's REM sleep. Very important, dream states, and look at when they occur, usually the second half of the night or the last third of the night. That's how the spouse may miss hearing the choking, miss witnessing the apneas, because it occurs in the second half, while the spouse usually is already in deep sleep. Signs of OSA, hypertension, 50 to 60% will get hypertension. Initially intermittent, later will be persistent. And especially during the episode of hypoxia, when oxygen drops, the pressure usually will shoot up. And of course, here's a diagram showing the tonsils, how large they can be. Like this is very bad. They have different state implications for these tonsils. Just to make a note, it can be as large as this. So removing these kind of tonsils would be good to have. Like this uvula, they trim off, and this is the palate. Sometimes they even trim the palate. Okay, obviously this is a very obese person. Fat around the neck. We are only concentrating in this part because we are talking about obstructive sleep apnea. The other part, of course, obviously very fat, chunky obesity, but this is the metabolic syndrome and all. Obesity causes OSA, and OSA also causes obesity. So it's like a cycle. So why? Because OSA decreases leptin, which is used to the hormone to suppress the appetite of a person. And it also increases ghrelin, appetite stimulant hormone. So it works to make the person fat or eat more, and also reduces physical activity and other metabolic changes also. Obesity causes OSA, OSA causes obesity. It's one cycle. Receding chin. How you look at the receding chin? So I normally take a photograph, ask the person, borrow his handphone, take a person's profile picture, and you can measure from here the glabella to the upper lip, draw a line, and you can see how recessed it is. This is the receding chin. Similarly, here to there, you can see the chin. So when the chin is small, jaw is small, so inside will be compressed. Fat accumulation around the neck, obesity, and also lack skin from aging, or some are genetically predisposed. You find that it compresses the neck structures, and also the inner structures also will be compressed by the external fat. So we also measure the neck size. So 17 inches, if you have a measuring tape, if it's 17 inches for men, very likely to have OSA. 16 inches for women, very likely. And why is it? If you look at it, if you go to the gym, you find that men or women, they, especially men, will come out of the gym, you find that they have big neck. Why is that? Why that the gym goers have big necks? Why? Sometimes they go to the gym and after they do these flexion extension exercises and then shoulder shrugs, because all these shoulder shrugs and all the muscles in the neck are involved. And upper limb, last session here, we talked about the upper limb structures, remember? And the how to breathe using the accessory muscles respiration. So these are connected with the upper limb girdle. So when they exercise the upper limbs, these muscles also get exercised and they hypertrophy. That's why they get a thick neck. So when we measure their necks, men 17 inches or more, they usually have OSA. And of course, overweight obesity is fat on the neck. So Singapore Health Study in 2012, they studied 2,400 citizens aged 18 to 79. What did they find? 30.5% had moderate to severe OSA. Which is a lot different as Singaporeans, do you see fat Singaporeans? Next question would be why? Why are they getting OSA? So the reason is that the male, more often in the males, they do overweight, if they're overweight, and the middle to older. And they got these facial features, small receding jaws. That is the reason. Chinese more than Malays, more than Indians in that ratio. And 91% with moderate to severe OSA are not aware of their condition. because they are not diagnosed. So it's a major health problem. So in Asia, lower obesity rates, but because of the cranial features, they are more likely to have OSA. And also, they have a lower respiratory arousal threshold. That's why they get fragmented sleep. The threshold for being aroused from lesser obstruction causes them to have more fragmented sleep and therefore excessive daytime sleepiness. Sleep study for OSA, commonly we use level 3. Level 3 means technician or the person, if educated enough, can actually put the device on themselves. So usually a breathing belt over the chest, position sensor over the chest here, oxygen, testing the oxygen saturation, airflow, a nasal cannula to detect airflow. That's all. That is known as level 3 home sleep apnea test. They all offer the test. The technician will go there at your home. They will just lie with you, what time, where you stay. They will just go there, put the machine on. They will teach you where to press the button to switch it on, and then they will leave. Tomorrow, the next day, they'll come and collect back the equipment, the small little equipment, little memory bank here. They will put it into a computer and make a diagnosis. And the results will come to us. They will tell you what needs to be done next. Level 2, a little bit more. Now we have the brain waves, some muscle detection, and also the eye movement. So the extra leads on the upper part of the face. The others are the same. Sometimes they got EKG as well. And of course, level 1 is a full PSG. Full PSG, only very few hospitals can do it, but it's very expensive. Costs about $1,000 to do this sleep study. Mainly, concentration is the cranial sensors in the head. Also, sometimes they have the leg or the leg movement, and maybe an additional belt over the abdomen. 2 belts, chest belt and the abdominal belt. So that it will be a full PSG. And the full PSG is very important when we fail to make a diagnosis using the home sleep study device. But the patient is still having this excessive daytime sleepiness. PSG is a polysomnogram. So this is what we get for full PSG. Brain waves, waves of the eye movement, the chin, the submental muscle, heart, breathing, chest, abdominal belt, additionally over the legs as well. So this is very complicated, right? So this was. Now this is the home sleep study. This is a real person. I took it from the my computer screen. So as you can see, so stop breathing, right? And you can see this is the oxygen fluctuating. As the person stops breathing, the oxygen drops. And this is a graph showing how low the oxygen can be. You know, it's dropped down to below even 60%. So this is 97, 98. It's normal. The person drops to 60%. Now, the next question, how to get the person to wear a mask like this to show him or her how dangerous the person's condition is? Very simple. What I normally do is that I put a pulse oximeter over him or her, tell him or her, your figures show that you have dropped the oxygen during sleep and has dropped to 60%. Okay, now we do a test. Look at your watch. Let's say you have a pulse oximeter. So oxygen now should be about 97, 98. Hold your breath. Take a deep breath, hold your breath, and then don't breathe. And wait until you cannot hold anymore. And then you see the oxygen saturation. It does not drop very much. Maybe most of the time when they are 97, 98, it drops maybe 2-3%. They cannot hold the breath anymore. They have to breathe. The question to you is that, how is that this person still walking around, is so lucky that he's still walking around but detected early, that he can drop his oxygen to 60%. And when he does the test that I just mentioned, he cannot do. When he's awake, he cannot hold his breath, and the oxygen does not drop to 60%. Drop to 2-3%, he has to breathe already. Why? How is it possible? How is it possible that you have a reading like this in a real person? And it's very common, you know. And I can tell you, I got 1 or 2 so bad, USA, so sleepy, so while having a consultation standing, they fall asleep leaning against the wall. Can you imagine? It's that bad, that bad. So how's that? It's because when we sleep, our senses are numbed. We do not detect oxygen desaturation so well. And then, because our senses are numb, we do not respond as fast when the brain is telling us danger, 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 ringing an alarm bell. And the muscles are so relaxed. So it takes some time for us to pick up the breathing, to pick it up. So that's the reason why. So in the sleep study, simple one, we can find what level of events they have had. Normally, you can have up to 5 events per hour, normally allowed. But if you have 5 or more, up to 14 is mild. 15 to 30, it is moderate. And beyond 30 events per hour, it is severe. And of course, moderate to severe, definitely advise the machine. Definitely advise the machine. Mild ones, we will see what the person has. Maybe there are other treatment choices. So why recommend the machine? Why recommend the machine, which is the gold standard for us? Machine first. Why? Because as I've illustrated earlier, the level of blockage could be at this level, nose level, the mouth level, oropharynx, or near the larynx, the voice box area. So 3 different areas. So with a machine like this, it doesn't bother which level of blockage. As long as there's blockage, it senses and it pushes air and uses air to spin open any area which is blocked. If one has to go for surgery, if it's not compliant to this machine, has to go for surgery, the doctor has to do the scope, find out which area is actually blocking, and tackle that particular area to have surgical success. Otherwise, the surgery is done is not successful. Wrong area, cut off the wrong plant. You know what I mean? Too bad. Suffer the pain, cut out the wrong part. So they must do. So for this gold standard thingy, and it's simple and it's not very expensive, is to push air, open up all the 3 places wherever they are blocked. Simple as that. But of course, non-compliance 30 to 50%, because it could be the mask. We cannot get used to it, something there, something somehow, you know, after several years, they may get this non-compliance. So, what are the alternatives to CPAP therapy? There are a few. We will go through them. Positional therapy, if we find that in the sleep study, most of the obstruction occurs in a particular position, then we will try to avoid the position. Oral devices, weight loss must lose weight. Even a little will be helpful, because, and then when you use the machine, it's more comfortable, because when you lose a bit of weight, the machine doesn't require so much pressure to push. Then the person is going to be more compliant with the machine, because more comfortable. You don't have to let the machine send so much pressure into the person. So losing weight is definitely very good. And limit alcohol. The last drink is 6 p.m. because we don't want them to sleep, not oversleep and never wake up. That is the danger. And avoid sleeping tablets. Avoid sleeping tablets. And it's very dangerous for doctors. If the patient comes to the clinic and tells the doctor, I have very bad sleep, because these patients all have unrefreshing, disturbed sleep. I got very bad sleep, and I wake up, I'm very sleepy. And if the doctor doesn't ask any more questions, whether he has been a loud snorer or not, and simply give a high dose of sleeping tablet, what happens? He's going to sleep deeply. All the sensing mechanism of low oxygen when the blockage occurs will be gotten rid of. And he may sleep and never wake up. So that's the danger of this sleeping tablet. You must always ask whether the person has been having loud snoring or not, and the sleep apnea. And of course, if there's nasal problem, to treat the nasal allergy. So surgical treatment, cut palate, suspend hyoid bone, expand the maxilla, advance the maxilla and the mandible, tongue reduction, cut hypoglossal nerve stimulation, stimulate the nerves, right? So a lot of things that the surgeon can do. So we'll go through it very quickly. Now, of course, the main gold standard is still CPAP because there is limited success with all the things that we do otherwise. Success rate, you see 100%? No, isn't it? Some are not so good, some are better. Of course, these are very advanced surgery. A lot of things have been removed. If the sleep study shows that position is the main culprit, lying flat, head up, all or most 80% of the obstruction occurs, then very simple. Get a backpack, a small one, a child's one, and then fill it with blood so that the person doesn't turn back. Lumbar binders. 3 tennis balls, just sew into your pajamas. 3 tennis balls, sew into the pajamas, that's it. You know, when you turn back, hey, turn back. And fetch pillows, full length pillows, or posture alarm. Mandibular advance. These are all fitted by dentists. See, you put this thing at night, you know, you put this on the sculpture up, over the teeth, upper teeth, lower teeth, you will adjust this through. Each time you put up there, it bounces forward. So this is so the problem is this with joint pain, salivation. So this is a simple dental device. Tongue retaining device. Look at this. So very simple. You can also put yourself, put the thing, stuck the tongue, so it won't fall back in. That's it. Retaining device. Complete airway repositioning expansion oral appliances. Something like this, but more a bigger device. When you put there, adjust the screws so everything will be put forward so that it won't block at the back. And the negative pressure therapy, INAP. This is the device whereby there is a suction pump placed at night, fitted over the mouth. Here, the catheter will suck out the air, very quietly suck out the air so that the tongue falls forward. The tongue falls backwards. Because of negative pressure, the tongue will be sucked out. And now this one is the hypoglossal nerve stimulation. Yeah, the implanted ones, when you need to do surgery, you have to plant electrodes like here. This is the device, electrical device, impulses are sent. This is a sensor lead, sense when the person is breathing. And it will send an impulse to stimulate the nerve. All these are implanted into the body, you know, underneath the skin. These are all placed beneath the skin. This stimulation device is actually wrapped around the hypoglossal nerve. So this is really advanced surgery. And here we have a non-implant Excite OSA, whereby this is the battery here is actually to stimulate the tongue. This one is used in the day. When you put in there, the device will give little currents to tighten the muscles of the tongue, make the tongue tight so that it's not so floppy. So the tongue, so they say the change of muscles, fiber of the tongue, stiffen up the tongue. And tonsil removal, effective in children, not so effective in adults. The UPP, so we simply just cut. Alright, you cut the uvula, you cut the soft palate, you cut the middle of the tongue, or you stiffen the tongue with high frequency waves, and then therefore this will be enlarged. I think it will be better. And of course, we have had people who have undergone this surgery. The problem is overseas surgery, they regurgitate. When they swallow, something gets into the nose because they cut off too much of the soft palate. So because the soft palate, as you swallow, the soft palate will rise big so that whatever you swallow will go down, won't go up to your nose. So you cut too much, surgery not well done, you will regurgitate. So we have people who have done that and got this problem. Most of the time, the surgery is successful. And here, very advanced surgery, receding chin after surgery looks good. And what do they do? This is really remarkable. This bone, the maxilla, they cut. Okay, and then they plate and they screw. This jaw, they also cut the bone and then they plate and they screw, making it come forward. And this bone, jaw bone, also they cut and swing it forward with plate and screw. So that's why the whole thing can come out like that. That's how they do. This is advanced surgery, come in stages. So that it can be done. Remarkable, isn't it? Final part of the talk already. OSA serious consequences. Stroke 2 to 4 times risk. And if after a stroke, anybody who had a stroke, you must ask for whether the person has been snoring or not. Because if the person has been snoring and now already has a stroke, we'll make sure he doesn't get another stroke, which may be fatal. Commonly, we will ask for a sleep study if the person is a snorer. Even a mild snorer, we must do a sleep study to prevent the next stroke. And the strokes are ischemic because of hypoxia. And it's caused by the inflammation, the increased fibrinogen, and of course the decreased blood viscosity. When the oxygen drops, causes inflammation, systemic inflammation. Oxygen drops, hypoxia, the body gets damaged. There's inflammation, and a lot of things occur. Heart attack, 2 times risk. Initially, the hypoxia drops oxygen, blood pressure increases, sympathetic nerve stimulation occurs, the heart beats faster, there may be blood pressure increase, again inflammation. Inflammation can cause a lot of problems. And of course, in heart failure, sometimes there may be associated central sleep apnea, where the person does not have airflow due to a central cause. There is no movement of the chest or the abdomen. Whereas in obstructive, there will be movement of the chest and abdomen because the person continues to breathe. Whereas in central, the breathing muscles of the chest and the abdomen are not there. There's a central apnea. So other problems, atrial fibrillation, that is irregular heartbeat, metabolic syndrome like diabetes mellitus, and of course, premature death. So, ask you a few questions. Why is OSA ignored in this part of the world? Why is OSA or the loud snoring observed ignored? So very commonly, the people will dismiss it. Just noisy, he's just noisy, sleep in another bed. Hello? The spouse will sleep in another bed. That's it. Problem gone. Because the spouse doesn't hear, the person doesn't know. Problem bye-bye, gone. This problem is solved. It's a joke. Our culture says that it's a joke because the louder person snores, the more relaxed the more enjoy his sleep. Isn't it? That's what we Asians think it. The louder the person snores, the more he's having good sleep. Yeah, and the person not awake while sleeping. Alright, that's because of the REM sleep in the later half and the last part of the sleep cycle. And very commonly unable to judge severity of daytime sleepiness. So if you don't do the scoring, as one goes through this spectrum of a mild, moderate, severe, you get used to the excessive daytime sleepiness.係咁噶，when you say都係咁噶，咁多年咗，老都係咁噶，but actually it's getting worse and worse. So inability to judge. So you must do the scoring, then you will be more objective. So various excuses of daytime sleepiness. Oh, 尋日做工做多好辛苦啊！it's a common one. It's snoring loudly because it's overworked. Never rest.
Actually, there's so many now.
Yeah.
Daytime they feel so sleepy.
That's
so
right.
How are we going to
No,
judge?
that may be OSA or sleep deprivation. Very commonly, the young people have sleep deprivation. So you must decide which is which. But snoring is the one. If you're loud snoring, you must come forward. You must come forward for investigation. So in summary, it's prevalent, easy to identify, there is very good effective treatment, and it's associated with ill health and death.